Look, these are different animals than the hospital cath lab, and these are much different animals than a physician office-based lab.
It's completely changed cardiovascular medicine's ability to effectively leverage the procedural setting for the betterment of providers and truly, and most importantly, patients.
When it comes to cardiovascular care on the organizational level, MedAxiom understands the challenges your program is facing. Welcome to MedAxiom HeartTalk, the podcast where thought leaders come together for one ultimate goal: to continually transform cardiovascular care for all. MedAxiom HeartTalk starts now.
I'm Melanie Lawson, a journalist in Jacksonville, Florida, and host of MedAxiom HeartTalk. I am excited to introduce today's topic, the evolution of ambulatory surgery centers, or ASCs, and what this means for you and your practice or group. Our guests today are Marc Toth, Market President, Cardiovascular Services at Atlas Healthcare Partners. Also joining us today is Joe Sasson, Chief Commercial Officer and Executive Vice President for MedAxiom Ventures. Welcome to the podcast, both Marc and Joe. It's great to have you.
Thanks, Melanie. Happy to be here with you and Joe.
Yeah, thanks, Melanie. Glad to be here with you and Marc today.
All right. Well, there's lots to say about both of you, very impressive experts in your fields, but we do encourage everyone to read their full bios and the episode notes to learn more about our guests today. So the first question that we do ask all Heart Talk guests, it's an easy one, but it gives us a little idea about who you are and why you got into this business. So Marc, let's ask you, why did you decide to get into healthcare? And maybe did you ever have that aha moment?
That's a great question. I started selling heart-lung machines a long time ago, and being in the cardiovascular OR, seeing heart surgery performed was intoxicating. So from there, my career revolved in the cardiovascular space. But to me, the real aha moment was in 2020 when Medicare added PCI, heart stents, to the covered procedure list for surgery centers. We had talked about it for years. We had speculated. We had written papers saying, hey, here's why Medicare should approve PCI. And when they did in 2020, it really, to me, set off a wave that's going to continue to push this out migration of CV procedures into the surgery center. So that, for me, was my aha moment.
Not even that long ago. So it's nice to still have them, right? When we're in an industry. Joe, same question for you. Why did you get into the business?
I don't think that I had an aha moment as a bunch of smaller aha moments throughout time. And I think my love for healthcare really has evolved over the years. I kind of fell into healthcare and cardiovascular care many years ago while I was a professor at a university here in Florida. And without reliving the entire story, I will just say that I've had numerous personal experiences since I've come into the healthcare domain that have really endeared me to healthcare and cardiovascular care specifically, which I've been involved in for almost 2 decades now. And so it's truly a passion and a labor of love for me to really improve cardiovascular medicine along all 4 components of the quadruple aim. And that today's discussion is one that's really important to me as well, because this whole notion of ambulatory surgery centers coming to cardiovascular care really helps me to fulfill, I think, my life's mission.
That's neat to hear for sure. All right, so let's delve right into this conversation. Joe, when we talk about ASCs in today's cardiovascular healthcare landscape, the first thing our Heart Talk listeners might be thinking is change. We've seen so much of it lately. For those who might be unfamiliar, what is an ASC? And can you describe the evolution that has occurred just in the last 2 to 3 years?
Yeah. Well, an ASC is an ambulatory surgery center, although my bias is really towards calling it an ambulatory procedural center, because much of what we do in today's ASCs, especially in cardiovascular care, is procedural as opposed to surgical. And ASCs have been popular for years in specialties like orthopedics and GI and pain. But the introduction of these cardiovascular procedures came about with them being covered by CMS in 2020, as Marc noted. And it's completely changed cardiovascular medicine's ability to effectively leverage the procedural setting for the betterment of providers, provider organizations, payers, and truly, and most importantly, patients. So as new procedures continue to be added, cardiovascular programs are now determining what their role is going to be in this space, and their own ambulatory strategy, and how it affects their hospital lab strategy, and the clinical, financial, and operational challenges that need to be tackled for success. So as this is a major shift, and as you've noted, this shift has come very rapidly, the realization is that this is not a fad and it's not going away soon. And so despite the very fast onset, there's not going to be a fast exit on this. Other specialties have been down this road and they remain very viable in their centers. And we see no apparent warning signs on the horizon that this will not become a durable strategy in CV. And in fact, we think it's the future of cardiovascular care. And those that are at the table today are going to best be able to capture the advantages that this strategy provides by becoming first movers in the space.
Marc, let me ask you a similar question, because what does this evolution mean for cardiovascular groups?
Yeah, Joe made a couple of good points. I'll start with saying the evolution of this out-migration is here to stay. As Joe said, it's not a trend. And I really think for employee groups, if we look at groups and look at employee groups and independents, for employee groups, it can be the opportunity for them to be part of a joint venture ASC with their health system, where they can deliver high quality care in a low cost, more comfortable and convenient setting, where they have ownership and they have much more control in the day-to-day operations and in the supply. So they have some skin in the game. I think Joe used a good term, fast movers. A lot of health systems now are trying to understand, what does this mean? What does this out migration mean to their bigger picture health system strategy? And how can they be a first mover? Like some systems, Banner Health System in Arizona has been a first mover, understanding the shift is on and they want to be part of it. Other health systems want to be fast followers. Other health systems don't even have a strategy. So I think really for the cardiology groups who are employed, it's up to them to lobby their administrators and lobby their CV service line director about what this means from an offensive and a defensive strategy in the marketplace for recruitment and retention of cardiologists who can come work for the health system and be part of a surgery center, and offensively take market share from their competitors. So there's a lot that goes into the strategy that's usually made at the health system level. But I think the employed cardiologist can really, like I said, lobby or lean on the administrators to consider this strategy. For the independent cardiologists who are a minority of the cardiologists in the country, they've got opportunities to either A, do the center themselves, the do-it-yourself model, which is difficult, and many cardiology groups are doing that, or B, be part of the joint venture with the health system. So they would align themselves, as Joe likes to say, picking winners and losers. They would pick a health system in their market and theoretically align with that health system, invest in their surgery center, and with that often comes benefits like participation in their high value insurance network or participation in a co-management agreement. So for the independents, doing it yourself is a tough road. We've seen many fail in Arizona, and some are just getting started, and it's a tricky thing to do. But they now have opportunities to do it on their own or joint venture with a health system.
I think that's really smart, Marc. And I think one of the things that you just said that really stood out to me is it's not just about the procedure, or it's not just about physician investment, and it's not just about the care that we can deliver to a patient in a lower cost setting. When you take a step up and look at the macro environment in which these are taking place, the strategy for each of these people involved in terms of how do we improve patient care, unify the health system, work through issues of physician recruitment and retention. There's a lot of strategy to doing this right, as opposed to, building a building or retrofitting a building and putting a cath lab in there. That's not the ultimate goal. And that would be very short-sighted. And I think your comments point out the larger strategy that has to drive the operations and the investment and the financing and the partnership strategy around these. So I thought that was really, really well said.
Yeah, I mean, you both are saying this is something that you believe is really going to expand and get bigger. So you want to start off right and get it right and get that foundation built strong. So what has been the overall response so far by leaders in CV medicine, Joe?
Well, I think that leaders, again, leading in CV medicine, they're not waiting on the sidelines. It makes so much sense for all of these stakeholders. Again, as Marc mentioned, even for the existing health systems that may be pulling some volume from their labs, it still makes sense for them when done strategically correct. So the programs, providers, payers, patients, it makes sense for everybody that the leaders are actually rushing to market with their centers today. And I think, to be clear, rushing to market is no way a bad thing. It's not saying that we're compromising quality. There's nothing negative about this rush, because the rush in healthcare can make people nervous. What it is it's really a demonstration of comprehensive thinking about the marketplace. And it's likely indicative of a very sophisticated leadership team and very committed physicians and very intelligent health systems to move this forward quickly. Because we're seeing these centers today at various stages of evolution in every state in which it's reasonable to open these centers, because there are different state by state restrictions that are affecting the adoption curve here. And for the states where they cannot be opened easily, there's massive advocacy campaigns. So you can open centers and make sure that the scope of practice laws allow for cardiovascular procedures to be conducted, or applications are storming in states that have certificate of need regulations where you have to justify the existence of another healthcare facility like this. So the leaders are out there doing what they do best. They're leading, they're running, they're moving quickly so that we can really better meet patient needs and payer strategies.
Yeah, Joe, I think those are great comments. I look at leaders in CV medicine and look at the societies. ACC and SCI both supported this shift of PCI to the surgery centers. They came out publicly with statements supporting that. So to me, when you have the societies supporting this shift, especially a procedure like PCI, again, I think that's the watershed case that shifted. I think it's really telling that those societies are supporting this shift.
And not only the industry societies, as you're talking about, I mean, the patients are asking for this. So as you're talking about this advocacy, you're going to hear patients talking more about it. So it's almost something that it makes sense to jump on board and do this the right way and get that strong foundation and follow it through. And Marc, I mean, I'm sure you're seeing that, working in this industry.
Yeah, it's not going anywhere. And leaders from, speaking of advocacy, ASCA, which is the one of the lobbying firms that lobbies for ASCs, has been supporting and helped nominate procedures to shift to the surgery center site of service. So we've got advocacy, we've got local leaders, we've got societies, we've got a lot of tailwind behind this shift.
All right. Well, this sounds like an excellent place to do a quick pause for a quick message for our Heart Talk listeners. We'll be right back. You hear the term care transformation a lot, but what does it mean exactly? Care transformation is redefining the way consumers buy and use healthcare by developing new products, treatments, and business models that integrate separate healthcare organizations or activities. MedAxiom understands that moving the needle in CV care is not simple. It takes vision and leadership, and it requires bridging technology, innovation, and care delivery. MedAxiom experts are helping programs across the country shape the future of cardiovascular care delivery. Through education, organizational performance solutions, and advocacy, we are evolving disease management, innovating virtual care, driving the data revolution, and redefining access and team-based care. Let's transform cardiovascular care together. Get started at medaxiom.com/care transformation. Welcome back. So we have been talking big picture about the evolution of ASCs and what that means for you. So let's dive just a little deeper right now. Marc, let me ask you, you've been working to open and manage cardiovascular ambulatory surgery centers with Banner Health. You talked about that earlier, and operating several ASCs across the country. What are the first steps CV programs should take if they are considering starting an ASC?
We get that question asked frequently. I think really the first step is to take a big picture look and integrate the ASC into the overall health system long-term strategy. What are the goals? What's the impact on the cath lab? How does this affect our managed care lives if the health system has a managed care tool? What's the backfill strategy in the lab? So those big picture questions need to be answered because it's not a small venture to open an ASC. First of all, it takes 2 to 3 years. So we unfortunately, we can't open these in 6 months. So it's really got to be long-term planning. How does it fit into the overall strategy? And how are you going to make up the gap when some of these cases shift out? I think secondly, and the important question is for the health system to determine which physicians will be invited to invest in the JV. Is it just employed physicians? Is it a mix of independent and employed? Will vascular surgeons or radiologists be involved? There's a lot of nuances in anti-kickback status regulations that prevent some types of cardiologists from investing. For example, a general cardiologist or a heart failure cardiologist technically can't invest in a surgery center. There are structures and ways to work around that legally, but these are big questions that the health system needs to understand. Who do they want investing in these centers? And finally, I think they need to determine if they have the skill set, that is the health system, and the bandwidth to do the joint venture surgery center themselves, or if it makes sense to bring in a partner.
That does make sense, especially when you're talking about 2 or 3 years. Joe, opening up and operating an ASC does sound complex. At the same time, an ASC can be highly beneficial once it's up and running. So can you explain some of those key benefits to an ASC and the importance of a partnership where everyone benefits and really buys into the process?
Yeah, we've talked about this from a patient care perspective and from programs and from health system strategy, and we've kind of looked at the win all the way around the horn on this one. And one of the things I mentioned earlier, which I didn't elaborate on because I think it's so understood in healthcare, is the quadruple aim, which is really 4 components of driving quality care. One being maybe improving the quality of care. 2 is lowering cost. 3 would be patient experience, and 4 could be provider satisfaction. So how are we driving benefits to all of these stakeholders in the healthcare system? And I think when I look at, to answer your question about where everyone benefits, it continues to come to mind. I think, first of all, with ASCs, they give providers more control over their staffing, procedure scheduling, and how they want to practice high quality medicine. They have more control over that environment. And when they have more control over that, they also have more control over the outcome. And the onus lies on that provider to bring the highest quality care to the table. So I think that's really good for all patients, and it creates a sense of autonomy for that provider and how they're going to practice. Also, as we've talked about, from a cost perspective and kind of a program perspective, it's a great physician acquisition strategy and retention strategy. And so with an ASC, a program can have benefits that allow physicians to really buy into the ASC and use that as a deepening of the relationship or a recruitment tool. And Marc's pointed that out, and a way to even retain physicians that want to balance the benefits of an employment relationship with their entrepreneurial spirit. Because remember, up until 2007, 2008, most of these groups were all run by physicians, and they were entrepreneurial before the great migration of physicians into the hospital and healthcare systems. So there's this opportunity now to balance that entrepreneurial spirit with the benefits of alignment with a hospital or health system. And it can also free up for the hospital resources for more complex procedures, because you're taking the lower acuity procedures and you're moving them to a less intensive setting of care. And Marc also touched on that. As he said, it's not just about moving the procedures out of the hospital, but what is your backfill strategy for the hospital? So I think it allows new opportunities for the hospitals and various service lines. When we get to cost specifically, the benefits go to the payers. And for them, it's really a lower cost site of service with much lower reimbursement in the ASC than in the hospital. So the payers are paying less, which in theory is also a strategy for lowering healthcare premiums to the patient as well. Because if payers pay less, that should go downhill so that the patients pay less. And so, theoretically, that's going to be a benefit to the patient, but even more so, there's immediate benefits in terms of patient convenience. And so ASCs are really known for being less complicated to navigate, from parking your car to checking in to discharge after your procedure. And the patient experience tends to be better, as reflected by numerous patient experience surveys. Now, as a patient, personally, if I could have the same physician that I could have in the hospital, and I could have that at a lower cost to me and have a better experience, then that's a great benefit. And it's really keeping the patient at the center of this equation. And the patient is the most critical part of this entire strategy. So I think everybody can win, Melanie.
Yeah, definitely a win-win. And I think with patients being so vocal and so tapped into their care and what they're spending, this is a way to really accomplish that and make it clear that it is a winning strategy. Marc, medical writer Dr. Naveed Saleh says running an ASC can be challenging due to related regulatory and administrative concerns, and we've touched on those, and hiring a management company can help. So let's delve into this a little more. You touched on it earlier before we did our break, but I know the answer to this, but do you agree with this? And can you share more on when this might be an appropriate strategy?
Well, I know this is a podcast, but I'm smiling. And I'm smiling because this physician most likely already has a surgery center and he understands the complexities. I think the process goes when a physician wants to open his or her own surgery center. These are easy. My staff can do it. We'll open it. Then 3 years later, when they've gone through a couple of administrators and they've struggled, they're going to say what this physician says, that running these are challenging due to regulatory issues and administrative concerns. Hiring a management company can help. Look, these are different animals than the hospital cath lab, and these are much different animals than a physician office OBL, as we call it, an office-based lab. These are very complex entities from a design and construction, the regulations under which we fall, which are inspected by the Joint Commission, the same Joint Commission that comes to the hospital. Yet we don't want to build them like a hospital because it's overbuilding. So there are just so many nuances, starting from the architect. Too many times we've seen ASCs built to hospital standards because the architect was a hospital architect who has never done ASCs, and they overbuild. We see that often. Other times we see architects hired that built the cardiologist cottage in the mountains, and he's never done a surgery center, and now he or she struggles to put together an appropriate architectural and engineering plan and design and construction. I think after that, we certainly have seen the governance, the structure, the operating agreement, the legal documents, and the syndication of the ASC are very complicated documents. They're full of regulations and Stark law requirements that require a deep understanding of these issues. From a counsel, from a legal issue, building these centers, syndicating these centers is really complicated. And without counsel, you may run into problems just getting open, and you may run into problems 2 or 3 or 5 years down the road if you've crossed some line with Stark laws that you had ineligible physicians invested, or you've got a governance that doesn't make sense. So really understanding these are critical. And finally, the day-to-day operations are also different than a cath lab or an office-based lab. Keeping up with the number of procedures we do per day, we aim for 6 to 8 minute room turnaround. I don't think many hospitals have a 6 to 8 minute room turnaround. So we're a very efficient center, and to not understand that or to come from a hospital perspective can really make things more difficult when you're up and running the day-to-day experiences. So I'd have to agree with this position that a management company can help. They're not the answer, and there are some good ones and some that aren't so good, but certainly a team that has experience specifically in designing, building, syndicating, and running surgery centers is going to make your life a lot easier on your ASC journey.
Yeah, I love that. And coming from a perspective, you said 6 to 8 minutes. I mean, it's hard to fathom, that something could happen that quickly
Yep.
and the experience be positive, for the patient as well. Joe, let me ask you, and Marc, I'll ask you this one as well, but let's just look ahead. This is a newer space. So let's just try to predict 10 to 15 years from now. We could even do 5 because I think this is rapidly changing. But what changes do you predict we will see in this ASC space?
Yeah, I love that toning from 10 to 15 years down to 5 in your question, Melanie, because it is moving fast. And my crystal ball is decent, but it can't see 15 years, but I can certainly see 5. And I think that we are going to see more legal and regulatory changes that allow CV procedures to be performed in ASCs in more locations. And so whether that is scope of practice laws or certificate of need, we are going to see more centers open up across the country. And I think from a cost perspective, the healthcare system needs for that to happen. I also think that we're going to see more expansion of the types of procedures that can be done in an ASC. And so it's not just more volume through more ASCs, but it's a greater scope of services that enable the hospital to be able to free up its resources, as well as making sure that patients with varying diagnoses in need of varying procedures are able to get the same patient experience in their local community. So I see a lot of growth. I also see some things that are being done today in the hospital and the practice being brought into the ASC as a new site of care. And so whether that's diagnostics or whether it's follow around services, such as arrhythmia monitoring, or maybe intensive cardiac rehab post-procedure, I think they are going to be based around the ASC so that we can begin to offer patients that better experience of you can go more local to you and have a better experience at an ASC for your procedure, but also maybe for some of your diagnostics and some of your rehabilitative services as well. So I think the ASC is going to be a place of care, no different than we view the hospital or we view a physician practice today.
It's exciting. Marc, let me ask you same question and we'll pare it down to, where do you see the space in the next 5 years?
Yeah, Joe and I are on the same page. I do think surgery centers will be more than just episodic centers where you go in to get a stent or a pacemaker. Will it be imaging? Will it be PET scan? Will we be doing rehab? I'm not sure, but I think a lot of the newer technologies on the IOMT, the Internet of Medical Things, like wearables and some of those remote loop recorders that are implanted, I think we're going to see maybe there be a dashboard center in the surgery center that will monitor patients' wearables and patient implants. So more to come than just a place to go to a cath lab and get your stent put in. We're betting that Medicare will see the advantage of shifting those types of cases to the covered procedure list. Once they do that, again, I think these centers become much more than they are today. Maybe we'll call them something different than surgery centers. Joe calls them procedure centers. Maybe they'll be called the Heart Depot or some other term to describe these centers that are more than just surgery centers, because technically we're not doing surgery and we're providing a lot more care than just putting in stents.
Let me ask this, and either one of you all can take this, but I am curious in the CV space in the hospital, because if you're really talking about shifting some of these procedures to another location, Joe, I heard you talk about, maybe shifting some other things to the hospital, but what happens to our hospitals? You think about with COVID, a lot of our big buildings are just sitting empty because people are working from home. So do you see, the hospital being less of that gathering space, that main place for people to get procedures and more of these ASCs?
If I can take that, because I get this question asked every day, Melanie. It's a really good question. Hospitals are always going to be here, and we're always going to need acute centers to do acute cases and sick patients and high-risk patients. That's not the site of service the surgery center provides. We're not there for patients on ECMO or Impellas or very sick, complicated procedures. So the question is, what's the hospital strategy to backfill for this out migration? And there are a number of ways to do that. And I'll just highlight a couple that really make a lot of sense. So one is alignment with independent physicians. If a health system is in a market with independent physicians, aligning with them to gather more market share and say, hey, independent physicians, invest in our surgery centers and bring more of your acute cases to the hospital. And the health system can put those independents in their insurance high value network. They can create co-management agreements. They can do a lot more to grab more market share from their competitors to backfill those cases that are walking out the door into the surgery center. So I think that's probably the biggest and best way to combat this gap, as we call it, the gap of you're going to shift some cases out. Also, depending on in which market you live, there's organic growth. I'm in Arizona where 1,000 people a day are moving to Scottsdale. So there's just organic growth. And if the health system has a PCP network and has an insurance plan, then gathering those patients in a funnel that's growing is one way to just organically backfill the cases that are shifting out. But it certainly is on administrators' mind. The cath lab is a very profitable division of the hospital, and they want to fiercely protect that. They need to understand that those cases are probably going to shift out, whether it's to the competitive hospital or a private equity firm or some other vehicle that's going to take those cases out. And in Banner's instance in Arizona, Banner would rather have some ownership of those surgery centers than none. So I think developing a strategy with those backfill and the alignment is really key than just opening a surgery center.
Interesting. And there's time to do that. I think that's the exciting part is as we talk about this, there's time to make that adjustment. All right, Marc and Joe, what an interesting conversation. I can't wait to have it in a few years and see how things have changed. Thank you so much for sharing your time and expertise today on MedAxiom HeartTalk.
Thanks, Melanie. It's been my pleasure to participate and appreciate you having us.
Thanks, Melanie, for hosting. This was a great podcast.
Yeah, thanks, Marc. Thanks, Joe. Appreciate you both. Well, that is it for this episode. If you liked it, please tell your colleagues and let them know they can subscribe to MedAxiom HeartTalk on Apple, Google, or wherever they get their podcasts. If you would like to send us a note directly or suggest a topic, email us at hearttalk@medaxiom.com. Thanks so much for listening.